Thank you all so much for your patience and joining. We're so excited to have you be participating in the 2020 Action Forum hosted by the Coalition to End Social Isolation and Loneliness. It's my privilege as a member of the Coalition to End Social Isolation and Loneliness to introduce you to my colleague, Kasley Killam, who will be the founder of Social Health Labs, who will be moderating today's panel. Kasley, I'll let you take it from here. Thank you all so very much for joining us today.
Great, thank you so much, Carter, and welcome everyone. Thank you for joining this session today. So as Carter mentioned, my name is Kasley Killam. I'm the founder of Social Health Labs. I also have a master's from the Harvard School of Public Health, where I focused on solutions for loneliness, and I write about this topic for Scientific American and Psychology Today. And in my research and studies and writing, I've become convinced that in order to really move the needle on social isolation and loneliness, and to truly create a society and culture based around social well-being, we need cross-sector involvement. And that's why I'm so excited for this panel today. Over the next hour, we are going to hear from different leaders in different sectors, crossing transportation, healthcare, technology, and aging, and learn from them about how this is showing up in their work. So to get started, I'd like to invite each panelist to introduce themselves, to share how they see their organization's role in addressing social isolation and loneliness, and to tell us about any specific programs or initiatives that they run or plan to run related to this topic. So without further ado, I will turn it over to Dr. Nicole Cooper, who is the head of healthcare policy at Lyft. Nicole?
Good morning, everyone. It's so wonderful to be joining you all in this important forum. I'm Dr. Nicole Cooper. I have the pleasure of helping to lead the Lyft Healthcare team as the head of healthcare policy. I just actually joined the Lyft team just a few months ago in July of this year from a previous role at United Healthcare. And in my current role, I'm responsible for developing and managing Lyft's national healthcare policy agenda and working to expand Lyft's presence in the non-emergency medical transportation space, as well as supporting Lyft's broader healthcare strategy. And again, I'm very excited to be speaking with you all today. For those of you who are unfamiliar with Lyft, and I hope not many of you fall into that bucket, we are a leading national rideshare company whose mission is to improve people's lives through the world's best transportation. And I want to start by sharing that personally, I'm very committed to elevating Lyft's approach to addressing the needs of underserved communities across the country, including Medicaid and Medicare covered populations, rural communities, those who live in urban settings, and others who face difficulty with getting access to care and who struggle with various social determinants of health, social isolation, and gaining access to fresh, affordable food and other basic resources. Lyft's goal in the healthcare space is to increase access to care and to provide a needed intervention to address transportation insecurity and transportation barriers for communities that are disproportionately affected by the social determinants of health, namely Medicaid and Medicare covered enrollees, with a special focus placed on helping low-income communities and seniors across the country get the care that they need. We entered the healthcare space 4 years ago to ensure that patients have reliable rides to their medical appointments, and we have been the leading rideshare company in this space ever since. Now, you may be wondering, how can a transportation company impact people's health? Well, every year, at least 3.6 million Americans miss a medical appointment, and we largely think that this estimate is an underestimate and look forward to future estimates being done across the country. But the current data show us that at least 3.6 million Americans miss a medical appointment because they can't get there. On average, these patients are disproportionately poor, older, and people of color, and people with chronic illnesses. And this is a massive problem with huge costs to the healthcare system. Missed appointments and resulting care delays cost the U.S. healthcare system upwards of $150 billion annually. And missed appointments have a domino effect. When a patient is unable to meet their provider, they're less likely to use preventative services or to adhere to their treatment plan, and they're more likely to end up in the emergency room or have longer inpatient stays. So Lyft Healthcare serves Medicaid members, Medicare Advantage members, health system patients, and other health ecosystem partners to be a solution to this massive challenge. And we've seen some impressive results during the first 4 years of our entering into this space. including data that we just released in a white paper that was published by Fierce Healthcare just a few weeks ago. This white paper includes many important data points around how Lyft can and does play an important role for healthcare providers and health insurance companies across the country in doing three things primarily: improving access to preventive care, secondly, reducing the strain on overburdened emergency rooms, and thirdly, providing a better overall healthcare experience. We are indeed a trusted leading healthcare entity by leading healthcare organizations, and we've been developing strong partnerships. We have actually partnerships with 9 of the top 10 health systems and the top 5 payers nationally, in addition to the top healthcare transportation brokers across the country. And one of Lyft Healthcare's first signature partners in this space was actually CareMore. And I'm so happy that Robin, the Chief Togetherness Officer from CareMore, is on this panel with me, and I look forward to engaging with Robin on a discussion. But we chose CareMore as we noted that they were a particularly innovative, integrated health plan and provider in their mission to target and serve high-risk, chronically ill patients, including seniors with Medicare coverage. And we were able to successfully prove a few things about the Lyft Healthcare model through actually partnering with CareMore first over the last 3 years. First is that seniors will use rideshare if it is actually extended to them. And then secondly, that CareMore health plan, we saw that they reduced their average ride cost by 39% and lowered wait times by 45% by adding Lyft to their Medicare Advantage transportation benefit. Seeing the success, CareMore is now able to fulfill over 90% of its ambulatory outpatient healthcare rides via Lyft in their Medicare Advantage program. And hopefully we'll continue seeing such strong outcomes with other large payers and providers for years to come. Next slide, please. I also wanted to share with you all in talking about the impact that we've already seen with Lyft Healthcare and briefly sharing the results from Lyft's research partnership with the AARP, the University of Southern California Keck School of Medicine, and United Healthcare. A study was conducted just last year in 2019 to understand what the tangible impact would be in the lives of seniors that were provided unlimited and free access to Lyft rides with no predefined destinations. This study yielded some pretty interesting results and nicely illustrates the quantifiable impact that access to Lyft rides can have on addressing social isolation and for meaningfully supporting independence for seniors in particular. And Lyft is uniquely positioned to address these challenges. And I want to just quickly explain to you all how Lyft actually works in the healthcare space, because it is different from how you've interacted with the Lyft app before as everyday consumers. We have what we call Lyft Concierge, which is a dashboard specifically designed for healthcare. It's a B2B tool so that employees, whether it be a case manager, a call center agent, or a discharge nurse in an ER, can arrange transportation on behalf of the patient that the organization is actually paying for themselves. And a couple of features that we've designed with the healthcare population in mind and in thinking about patients who are particularly isolated and in need of transportation assistance. One is that the passenger doesn't need to have an app. In fact, they don't even need to have a smartphone or know how to work one. And that's very important for the case of seniors. And secondly, you do not have to have a phone. We push very simple SMS messages to allow the patient to help them find the ride. If the rider does not have a cell phone, we can provide the same logistical information via an automated call to a landline. And third, we send driver notes with details on pickup and drop off, like what the rider is wearing, whether or not they have a cane, and anything else that helps them recognize and meet their rider. And fourth, you can arrange different types of transportation depending on the patient's need. We provide on-demand rides as needed, and you can send a scheduled ride up to 7 days in advance, which works well when it's for an upcoming appointment, as well as providing what we call flexible ride, where a patient has the flexibility to call the ride when they're ready, for example, when they've completed their appointment. So with that, I think I'll end, and I look forward to this discussion to really further discuss the ways in which Lyft Healthcare is meeting the needs of particularly socially isolated individuals across the country. I look forward to engaging with this panel.
Wonderful. Thank you so much, Dr. Cooper. It's fascinating to learn how Lyft is helping with this issue and to see some of those early results. So next, we're going to hear from Robin Caruso, who is the Chief Togetherness Officer at CareMore Health. Robin, over to you.
Well, good morning, everyone. It's really nice to follow after Lyft because we have done so much work together around the area impacting loneliness and isolation. And it's hard to believe that it was over 3 years ago that we started our Togetherness program. We marched in 2017 in May with the CareMore population, and then we launched with all of Anthem Medicare in August of 2018. So if you go to the next slide, you know, when I started with a blank piece of paper and calling that first 100 patients, we really wanted to be the community and live connection for our patients who needed it the most. And remembering yesterday, David Brooks talking about, you know, seeing those patients, knowing those patients, it's really that power, that human connection that's really made the change in their lives. And so when we looked at the patient's journey, you know, it wasn't any kind of new scientific thing. It was really about making great relationships. And we did revamp our program in the beginning of this year, where all our staff now are community health workers. And that kind of came out of the first 2 years of working that we saw CareMore is a health delivery system that really works with complex care. And the more complex of these patients that we were seeing, sometimes were the barriers to their socialization, but it also was the barriers to their health, was their isolation. So we really revamped our program to have, and we call them social care partners because that's what we're doing. We're partnering with them to improve their overall health. And we're really working on engaging them back into their health care. And we've done that even by now, we're care planning them. We have our high-risk huddles to really identify those high-risk behaviors, but we're also looking to connect them to community-based organizations. Some are actually here on this panel, the people that we connect them to. And because we don't need to reinvent the wheel, you know, I always talk about Meals on Wheels has been doing this so long, and that was one of the #1 needs that they had, were connecting them to those community resources they needed for their social health. But we also were looking at things like getting them connected to what gives them love and passion and joy, bringing back that connection and purpose. So many had lost that through their lifetime, whether it was through losing their spouse who they used to go and do things with, or it was their failing health. And so we really looked to remove those barriers and connecting them to things like a photography class, or getting them to a senior center where they could meet people, just starting out with something simple like having a meal with someone and really growing those things. And then our outreach to our patients also include the caregivers. We know how impacted caregivers are by having that isolation from being the caregiver. So we really address that. And we're also looking at those newly widowed and those that are isolated at home because of their frailties where they can't get out. So really looking at those key clinical coordinations of really connecting them. And then as we started growing our program, we're like, how are we going to reach more people than what we're doing with our staff? And that's when we looked at our greatest asset, which are our associates. And so anyone throughout CareMore and all of Anthem could become a phone pal. And that's where we kind of gave them a pretty short training on how to have a great conversation. Most of us know how to talk to our family members, our aunts and uncles, our parents. And so we brought them into the thing where they partnered with us, where they would be calling them weekly. And one of the things that we find that it really connects our associates to our mission, that whole person care that we have. And many say, I think I'm getting more back from the patient's phone calls than actually they're giving to me. And so it's really nurturing and advocating and creating that relationship. And that's where the magic begins, is when they begin to be cared more about themselves by knowing others do, they start engaging more in their care because they care more about themselves, knowing that they're cared for by others. And that's kind of that whole patient experience. Yesterday when David was talking about kind of the weaving of, I think togetherness is really woven throughout all of CareMore. I always say everybody at CareMore is really part of the togetherness because all our touches and everything is to broaden that whole patient experience. And being part of the coalition is because we want to be that industry model to inspire others to say, hey, you can make the changes and you can make that difference. And we've even started our social groups virtually to really increase. Now with COVID, I'll throw in some of the things that we're doing. It's really hard that they can't go to our care centers anymore for the social group. So in August, we began starting, so much more of our program now is virtual, but the old-fashioned telephone calls have a significant impact. If you go to the next slide, one of the things is we wanted to take a look at what impact we were having. And so we did this during COVID, we weren't really sure. So we took a look at that, the survey, we looked at their social connections and asked them how many agreed that they had more meaning connections. 78% said that. And then increasing in their activities and things that they enjoy and bringing back that purpose. That's really a big big piece of our fabric in our program, and 79% agreed. And then of course, we're trying to re-engage them in their healthcare. And I love when we looked at this, that 74% said that they had improved their health. The 3 top activities were increasing their exercise, eating healthier, and also increasing their medication adherence. And I'll talk about Sarah. Sarah was one of our patients. When we called her, she was terrified to think about leaving her home and going to a senior center. One, she had some incontinence issues. She had a lot of health issues. Her diabetes was out of control. She was morbidly obese, had heart disease. Engaging in our program, she started eating healthier, and our social care partner was using things like getting her to go to the library to research healthier diets. She's lost 37 pounds in the program. And so those things are really exciting. But then when we went to look also at happiness, we saw, we knew it was during COVID, we didn't know what that would look like, but 66% said they felt happier while being part of our program. And the next slide. And then we recently just redid our data for our ASA Generations journal. If you haven't had a chance to see that, many on the coalition are part of that journal. But one of the things is that we have seen a 43% decrease in ER utilization. They kind of call us when they're having, you think about if you have a bad day, who do you call? And we're that connection a lot of times. And then we've also been able to reduce hospitalization rates. But really it's about how we're changing lives, and they are seen and they are heard. And those relationships that we're creating, we're now having them create that in the community, and they're able to graduate out of the program by creating those things. When I talked about Sarah, how she's graduating out, she's now leading 2 social groups on Well Connected, which is the Senior Center Without Walls, on quilting. So I'm real excited to talk about that. So I'll turn it over to the next panelist now.
Thank you so much, Robin. That was so inspiring. I love to learn about how you have included caregivers and your team members and all these different individuals to really create a community around this. So now we're going to hear from Cindy Jordan, who's the Chief Executive Officer of PICS Health. Cindy, over to you.
Thanks for having us on this panel. We're also super happy to be a part of this coalition. We're relatively new members, and the experience that we've had so far and the work that the coalition is doing is remarkable. So really grateful to be here. So you can see our mission on the screen here. It's to tackle loneliness when it matters most to everyone who needs it. And you can go to the next slide. So how do we do that, and what makes PICS Health like a little different is that we are kind of a first to market technology solution that is scalable, addressing loneliness and social isolation. Because at PICS, we don't believe that loneliness is a state of wellness. We believe it's a treatable chronic condition. And so, in order to really sort of combat that, you have to work inside of healthcare, and you have to, we work in conjunction with payers, et cetera, because otherwise, this, as we know, there's tons and tons and tons of research out there that members have a 47%, increased chance of mortality, et cetera. So by addressing loneliness as a chronic condition, you sort of offer treatments, if you will, and programs that are sustainable and available 24/7. So that brings to exactly what does PICS do? Well, we combine artificial intelligence and human intervention to serve the most vulnerable populations. Primarily right now, we serve Medicaid and Medicare Advantage members that have behavioral health diagnosis. So what does that mean, artificial intelligence and human intervention? Well, I'll start with the AI. That is our super cute, really funny, empathetic chatbot named Pixar, who is pictured here on this screen. And Pixar lives in a platform that can be accessed by members through their smartphone. We know that 86% of all the members we serve actually have a smartphone, albeit older models, but often don't have access to things like Wi-Fi. So we deliberately build a low data impact platform for our members to access through their smartphone. So let's talk a little bit more about Pixar. He acts just like a friend in a coffee shop to our end users. He's there when they need him. He most deliberately stays away from clinical. Like, he asks the member, the patient, how they're doing. Like, how are you feeling today? He doesn't treat them like a disease state or a diagnosis. It would be as if you and I are friends and we went out to a coffee shop, maybe pre-COVID, and we sat down and I was suffering from depression, and you said to me, we wouldn't sit down and you say, hey, Cindy, how's your depression? You'd say, Cindy, how are you feeling today? And that's what Pixar does. And the way that the end user interacts with him informs the self-management, et cetera, that he helps the member move through. We know that a 24/7 solution is critically important because of all the users in our platform that test lonely, 86% of them actually use the platform between the hours of 12 a.m. and 5 a.m. So loneliness and sleep are very highly correlated, and it doesn't shut off. And, it's not just a Monday through Friday, 9 to 5 kind of, condition that these members are dealing with. So now what do I mean by human intervention? Well, a robot can't do it all. So when somebody tells the robot that they're not doing well, and how do we score when somebody's not doing well? We screen for anxiety, depression, and social determinants of health and loneliness inside the app. We use the UCLA loneliness scale, the PHQ-8, the GAD-7, and then the Prepare for SDOH needs. And what I mean by that is, once Pixar has developed the trust of the end user, we will introduce these evidence-based screenings to really get a handle on the state that the end user is in. And when that user scores lonely or says they have an urgent social determinants of health need, our compassionate call center will reach out to them and intervene. And our compassionate call center is where all of our people are, and we call these people, every one of them, Andes, and Andy stands for authentic, nurturing, dependable, your friend. So the people that we serve have the platform and access to Pixar all the time. When they're not doing well, Andy reaches out and intervenes. And so I'm sure you're saying, well, that sounds great, but does it actually work? So we can go to the next slide. We had one of our first health plan partners, which was an MCO here in the Southwest that serves about 260,000 members. When we agreed, they were literally our first client. So what they said was, hey, look, it'll be good for you, it'll be good for us, but eventually we want to study the efficacy of whether or not PICS is actually working. So it took about 16 months, and with no input from us whatsoever, the plan took a group of PICS users, and there was about 1,170 of them, and compared them to a machine learning generated control group. So this was, they wanted it to be statistically significant, and our p-value was 0.001, as you can see there. So that means that the results that they found are statistically significant. And they studied a 6-month and 6 months post claims data. What did they find? They found that there was more than a $5,000 average savings per PICS member in a 6-month period of time. And our significant reductions were in ED utilization and inpatient stay. So I go back to the beginning about treating this loneliness as a chronic condition. We kind of prove that you can literally impact a person's cost to the system and their health outcomes. And so Anyway, that's just a little bit about what we do and how we do it. We work with many major Medicaid payers across the country and Medicare Advantage, and we're super happy to be here and answer any questions and participate in this lively discussion.
Great, thank you so much, Cindy. It's so interesting to learn about this innovative work, so thank you. And last but certainly not least, we are going to hear from Sandy Markwood, who is the Chief Executive Officer at the National Association of Area Agencies on Aging. So Sandy, looking forward to hearing from you.
Wonderful, thank you so much. Wonderful to be here and so thrilled because my organization represents community-based agencies across the United States. The National Association of Area Agencies on Aging, our membership is 622 area agencies on aging. And also we are the voice in Washington for over 256 Title VI tribal aging programs. And we're so pleased to be here and to be a founding member of the Coalition to End Social Isolation and Loneliness. I want to tell you a little bit about what our members do. If we could go to the next slide. When you're looking at area agencies on aging, and the same is true for Title VI, the tribal programs, serving older adults and caregivers in virtually every community in the nation. And the older adults are typically under the Older Americans Act, age 60 plus, but over 2/3 of area agencies on aging also serve people under the age of 60 with a functional or cognitive disability, impairment, or chronic illness. And when you're looking at the goals of area agencies on aging and Title VI programs, it's really to ensure that older adults can live well, can live safely at home and in the community for as long as possible. And in doing that, our goal is also to value and support them to live well at home and in the community. So the services that area agencies on aging and Title VI programs provide include meals, and we partner with Meals on Wheels America and also on transportation. So glad to have Lyft on this panel. Also providing personal care, chore services, health promotion programs, volunteer and social engagement activities, case management, and also caregiver support. So glad that that was raised as an issue. But all of these programs have a very important social engagement component. If we go to the next slide. And so when looking at the role that area agencies on aging play in combating social isolation and loneliness, pre-COVID, based on a survey we did of all the area agencies on aging in the country, over half of them were addressing social isolation during the care planning process, and 43% were assessing social isolation using a number of the evidence-based tools, and 36% assessing loneliness. Well, that's all changed since COVID hit. Social isolation for our members is now second only to ensuring that older adults in the community have access to food. Social isolation has become a paramount issue for older adults in the community and also their important caregivers. If we could go to the next slide. To respond to the needs of our members, to ensure that they have the resources to be able to respond to the needs of their constituents, the millions of older adults in this country, people living at home with disabilities and chronic illnesses, as well as their caregivers. Engaged the National Resource Center for Engaging Older Adults, which is funded by the Administration for Community Living. Our goal is to really provide outreach across the aging network, which is primarily our focus, which is to conduct polls and environmental scans to ensure that we understand what the priorities of the aging network are around combating social isolation and loneliness, and also to develop social engagement tools to be able to respond to those priorities. Additionally, looking at sharing good ideas and best practices that make a difference and being able to develop a clearinghouse so that those good ideas can be shared and adapted across the country. And we've done this particularly as COVID hit, looking at how different programs and services have been adapted to meet the COVID requirements for social distancing. How many programs have now gone virtual, and how many programs have expanded and adapted different types of programming to meet the social isolation and loneliness increases that we've seen throughout the aging population. And also to inform and engage. And here we recognize that since our members are community-based organizations, that they are touching, they're really connecting on a daily basis with older adults and caregivers. So we develop a range of materials that these agencies can co-brand, and other community-based organizations can co-brand, that really can be shared with older adults and caregivers to inform them about the signs and the symptoms of social isolation and loneliness, but in a way that is positive. As a previous speaker said, there's one thing, you don't walk in and ask an older adult, are you depressed? But you go through the assessment tools and look at messaging that would evoke an assessment on their part, and also their caregivers and also professionals in the aging network to be able to assist them, and not also to develop a roadmap to help them seek support and engagement opportunities in the community. So in addition to Engaged, N4A, through our membership base, also operates Dementia Friendly America and Dementia Friends USA, which are both initiatives that are targeted to meet the needs of people who are living in the community. 80% of people who have Alzheimer's and dementia are living in the community and are at greater risk of social isolation and also loneliness. And so through those, through Dementia Friendly Communities, Dementia Friendly America, Dementia Friends USA, we are also looking at developing tools for engagement. And lastly, N4A, as part of our elder care locator, again, a national call center that we operate for the Administration for Community Living, where we have millions of callers from older adults and caregivers across the country calling in, social isolation being an issue that is identified. This year, for our Home for the Holidays campaign, which will kick off in November, we're focusing in on social isolation and the mental health, behavioral health issues that are associated with it. And again, one of the great benefits of being part of the coalition to end social isolation and loneliness is we're all in this together. So we're hoping that the tools that we're developing through Engaged and through the Home for the Holidays with the Elder Care Locator, through Dementia Friendly America and Dementia Friends USA, can be utilized by all coalition members. With that, happy to answer any questions.
Thank you so much, Sandy. It's really interesting to hear about how the pandemic has influenced your work and how your team has adapted to meet those new needs. So now we are going to move to discussion. So perfect if we can get everyone's videos up. So we've heard a lot about the incredible impact that you have all had so far through your different programs. And I'd love to learn more about some of the challenges and learnings that you've had along the way as you've been launching and scaling these. And if there are any insights you can share that might be useful to others listening in who might want to tackle this issue through their organizations. So I'd love to hear from all of you, but perhaps we can start with Robin.
Well, one of the things is that being part of the coalition has really helped taking a look at like best practices and things that, you know, and hearing Sandy talk when I hear those things coming out, because those are the agencies we're working with. But it's also about, we're talking about creating relationships. We need those relationships too. But we also need to advocate for those that can't and really develop, you know, if we hadn't had some of the changes that have happened, that have been allowed through CMS, when we had this crisis with COVID, we had so many seniors before in healthcare, we couldn't pay for meals. And so we were able to, in that crisis, when their other sources of meals kind of stopped, that we were able to jump in there. So, you know, it's that synergy. You can do more when you're working together.
Absolutely. Thank you. Others, feel free to jump in to share some of the challenges and learnings and insights as you've launched these programs.
Kasley, I'm happy to jump in from the Lyft Healthcare perspective. Really, I'd love to just jump back briefly to the illuminating study that was funded by the AARP, USC, and United Healthcare that I briefly mentioned in my opening remarks. So I'm better drilling down, if you will, on that study and what we found, which was quite enlightening. Study participants were offered 3 months of free and unlimited Lyft rides, and they were all aged 60 years or older, and they all had chronic disease and self-reported transportation barriers. And in defining their specific transportation barriers and what was leading to them perhaps being isolated and lonely, the participants named financial issues, parking issues, car trouble, traffic stress, the social burden that they felt overall from asking friends and family to drive them where they wanted to go each day. And the original goal of this study was really to address social isolation and loneliness and to help the seniors involved in the study to get better and more meaningfully engaged within their local communities. So there was a dedicated emphasis placed on helping them to age in place and yet still have a sense of togetherness, and by providing critical transportation to and for them. So we were very proud to see that the results from the study showed that when participating seniors were provided with unlimited access to Lyft for those 3 months, that they increased their physical activity by 35%. And we saw at the end of the study that they self-reported 90% increase in quality of life, all based on having their mobility challenges removed. And highlighting the circumstances and the unique stories of just a few participants, I have two stories I want to share. Ken was a retired music producer who lived alone and received dialysis treatment 3 days a week. And in this particular study, he used Lyft transportation to maintain his independence as he aged in place. And then there was Connie, another participant who previously relied on her children and her grandchildren for rides and felt like she was imposing on them. And she used Lyft access to become more socially active in retirement. And she also was one of those participants who said she had a quality of life increase. And again, this work has reinforced for us that seniors will use Lyft if given the option to, and if helped with training, that is. And in fact, more than 4/5 of the participants in that study said that they would continue to use rideshare transportation, with the remaining 20% of the participants citing prohibitive costs as the primary barrier. And really, this highlights for us that subsidization for mobility and transportation supports can help further improve social isolation in the future, and thinking of specific policy change that's needed. And additionally, we found that almost all of the seniors learned to use the Lyft consumer app after receiving training, which I've already shared. And the seniors appreciated that Lyft was more likely to be on time, cheaper, felt safer, and was truly an alternative model and mode of transportation for them, based on how they were forced to rely on previous modes of transportation that were highly inconsistent. And interestingly enough, to the Lyft Healthcare team, while seniors did take Lyft to their medical appointments, that was only 12% of their usage. Our study showed that participants really wanted to go other places. They ran errands to the pharmacy, to salons, to fitness classes, to entertainment, and they engaged in social visits to see their friends. And of course, this was all pre-COVID back in 2019, when life was a little different for all of us. And so as Lyft Healthcare started to scale our programs and serving more seniors that are covered by the Medicare program and Medicare Advantage in particular, we really tried to put these important learnings into practice, and we continue to track a few additional learnings. For chronically ill patients that we transport, we're looking at their adherence to complex care programs and whether or not it's easier when you have reliable transportation, and we found that is the case. And being part of a community sort of really helps to stave off the negative consequences of social isolation. It's a theme, of course, from this panel and the broader sessions happening throughout this conference. And really this notion of how to best maintain independence for vulnerable people. And what motivates us at Lyft Healthcare is the uplifting, if you will, of this narrative, and uncovering the difference that we're making in the lives of consumers, and bringing much more consumerism to healthcare in particular, which has struggled in the past with those issues. And I will just briefly share that just last week, Lyft Healthcare thought long and hard about how we could better address the needs of the many populations we're trying to serve. And we announced that we're actually integrating with Epic, a leading electronic health record, that the majority of top-ranked health systems and hospitals utilize across the country to manage their patients. And we're working with them directly on what we call Lyft for Epic, and integrating and enabling health system staff to call Lyfts directly for their patients, directly from the patient's medical records in-house within a health system. And the Lyft for Epic integration will ensure that transportation is never a barrier to care for the organizations that partner with us in this way. And the integration will be available starting actually next month as part of Epic's November 2020 upgrade. So these are just some examples of the ways that we're enhancing what we do and what we learned, again, from this really informative study just conducted just last year.
Thank you so much, Dr. Cooper. Cindy or Sandy, would you like to share any challenges, learnings, insights as you've built up your programs?
I mean, for me, the challenge is also that in that same study that Dr. Cooper references, this is not just a senior problem, and community is not always the answer. And so when you look at transitional age youth, which is a demographic that we focus on, they are not socially isolated. In fact, they're generally in groups of many people, but they're profoundly lonely. And that loneliness is a precursor to other mental and behavioral health diagnosis. And so, in order to get them help, you can't just say, well, let's just throw you in with a whole bunch of other people your age and everything's going to be fine. It comes back to this idea of treating this like literally a chronic condition. And so if I'm lonely and Dr. Cooper's lonely and Robin's lonely, the treatment for me and them is going to be very different, right? And so that's where getting involved and figuring out from an evidence-based position where they really are, and then tailoring a program for them. So, for example, in transitional age youth, instead of doing a lot of phone calling like our Andes do, because the seniors love that, and they'll talk on the phone, as I'm sure Robin knows, for 30, 40 minutes, and we learn everything about them. Like somebody who's 18, 21 would rather have an Andy that texts with them. And so there's all kinds. Loneliness is legitimately not a problem that happens to you later in life. It's a perception that you have no connection. And so I think that's one of the challenges. Like I can tell you pre-COVID, I was talking till I was blue in the face about this kind of stuff. And even with the AARP study, which was amazing, but post-COVID, now people have been at home and maybe months and months and months on end, and they haven't seen their coworkers. And now there's this personal understanding of what it means to feel lonely, even in a household full of people. So I've seen it really start to open up, not just legislatively, but just from a personal understanding. And so I'm hoping that we don't go backwards, and that we take the lessons of COVID to understand that this is legitimately an issue that cuts across all age, all demographic, and AARP proved this, all socioeconomic status. Like, you don't have to be on Medicaid and be 65 years old to feel lonely.
Right. Cindy, I'm so glad. Focus is more older adults as well as people with a chronic illness and disabilities and their caregivers. But I couldn't agree with you that it's not as if the issue of social isolation and loneliness is age specific, because it's not. I think from a success point of view or an opportunity point of view, as you pointed out, that we all knew that the social isolation and loneliness were public health issues pre-COVID, but now the spotlight is on it. And quite honestly, everybody has felt those feelings of social isolation and loneliness. But I think the challenge here is keeping it in the spotlight and ensuring that we have the research to be able to back up what I believe needs to happen, which is investment in programs, in technology, in training, in assessments that really address this issue head on for all populations. And so as what I'm hoping is that we can all come together to do that. I think the Coalition to End Social Isolation and Loneliness is a great vehicle to do that. But I think that's the challenge. It's making sure that this, once a vaccine happens, that this doesn't go by the wayside, because it was an issue before and it'll be even more of an issue after the COVID crisis ever ends, and we hope it soon.
Absolutely. Thank you so much, Sandy, for raising that point. So to really leverage that momentum and the fact that the spotlight is on this issue right now, one of the missions of the coalition is to advance different policy to support social solutions for social isolation and loneliness. So I'd love each of your thoughts on kind of what policies you think either need to be changed or introduced to support some of the efforts that you're working on, as well as others in this space. And so perhaps Dr. Cooper, seeing as you lead policy for Lyft, we can start with you. Mm-hmm.
Sure, and I'll try to be brief. This question makes me think about a number of things, and Sandy hit it on the head, really, in thinking about, it's about policy change, it's about reframing, further investing in interventions and research, really, that can get us the answers around what's needed for various communities and various subpopulations that are facing these issues at increasing rates, given that we have a crisis on our hands. And so thinking about transportation in particular, which is my zone, it's an important supplemental benefit for both Medicaid and Medicare covered populations. And I'd like to see health plans in the federal government, and namely the CMS agency, continue to invest in transportation benefits at scale and nationally for the patients who need it most, and taking the point of view that mobility out into communities is part of the solution for many populations, not all, certainly. But when you think about many of the other social determinants of health, you can see how lack of access to transportation can and is a barrier to overcoming food security. It is a barrier to accessing education, training support, along with gainful employment and more. And so, the communities are largely left to be reliant on family members. And I know I called it out previously, and thinking about, the ways in which people feel like they're a burden on the people that love them. And so thinking about removing this particular barrier, the specific policy change that can be implemented by CMS, and opening up adoption and adding this as a guaranteed benefit for the populations that need it most. And then also investing briefly in policy informing healthcare research. And that's very, very important. And while previous interventions and research studies have begun to examine the impact of transportation barriers on medical access, these study designs have been limited in that they've not focused on many different types of older populations and older adults and other vulnerable populations. They've not really focused on technology adoption and additional aspects of health and well-being that we're all touching on as a collective panel. So I think we're missing a critical piece around research that can inform policy. And by thinking about patients in a more holistic manner, we can have a better shot at actually addressing their needs, at crafting federal policies that can enable mobility in particular as a core and central barrier to good health.
I guess I'll jump in here, like, very bluntly, and this is a sad state of healthcare, but we need a billing code, because everything will follow the money. And so back to this idea that loneliness and social isolation are chronic conditions, if there's a CPT code to follow them, then it won't just be a problem for Medicaid and Medicare Advantage and at-risk populations. It'll be something that everyone will address, including commercially insured, because it's really just a mind shift of thinking about it. And I agree with Sandy wholeheartedly that it has to come from the research. It has to come from a lot of data to prove, if you think about diabetes prevention. So there were lots of billing codes around diabetes and treating diabetes and giving insulin and all kinds of medicine to treat diabetes, but there was no billing codes around the prevention of diabetes, including, nutrition education, etc. To me, that is the same category that we are sitting in right now at a time when they were sitting in it, which is, if we can get the healthcare industry to embrace that this is actually a condition that needs to be treated and create a billing code around it, then all of this stuff will open up. And I think, just thinking of loneliness as a wellness opt-in kind of, problem is a mistake, because one of the things we see in our platform is almost 74% of people who test lonely on the UCLA loneliness scale identify not as lonely when given the opportunity, but as sad, worried, or anxious. So it's not an opt-in thing. People don't raise their hand and say, I'm lonely. You know, they feel different emotions around it. And so I don't have to drone on about this forever. I think we have to follow the money. We need to make this a billable chronic condition.
And Cindy, I just follow up and say, I think we need to invest in that from a policy angle. And I agree with you completely about a billing code. And I think the other part of that billing is to be able to create a stronger bridge between the acute care world and the world of home and community-based services, because by doing that, you will be able to address the issues across the board. And right now, if we just have billing codes on the healthcare side that can't then support the community service agencies to do their work, then I think we've only solved half the problem.
I actually was going to say that point, Sandy, and thinking one of the things is if we get the funding for healthcare, which like Sandy was saying, we have some of the things that we can do now, but we've recently done a pilot with Medicaid, and think about someone's life that you can impact connection early on and how it's going to impact their well-being. But if we don't also have that infrastructure in the community, because that's where healthcare can't do it all and be everything. And then the other challenge that we really have is there's so many behavioral health needs. And that was one of the things that when we revamped our program, one of our challenges was there's so much. And that, you know, we're supposed to have equal access to behavioral health needs as our healthcare needs. And that is still not. And that's something we have to do a better job. And we need policy to reinforce that. And then the funding to continue these programs. You know, the impact that COVID has had has brought everything to light, but it's really easy once that happens that it's kind of like, it sounds like we all have that same passion to keep it going. So that's something we're really going to have to do. And I'm glad we have the coalition that is a big part, is advocating and working towards making policy changes.
Excellent. Well, we are almost out of time, so I want to extend a deep thank you to each of you panelists for joining today and sharing your wisdom and really for leading the way in your different industries. And thank you to everyone who's attended, joined live. I know that I'm leaving this session feeling very inspired. There's also a lot of work to do, so hopefully we're all motivated coming out of this. But I'm certainly heartened to know that so many different industries are tackling this issue. So with that, any final words? All right. Well, we will thank you again, and we are going to now head back to the main session. Excuse me. So Carter, how should individuals do that?
Kasley, Dr. Cooper, Sandy, Cindy, Robin, thank you all so much for this. And as Kasley said, we are going to head back into the main room. So my colleague, Michael Boudros, has just put into the chat the link back to the main room. So you can literally just click that link and you'll get a pop-up and select yes, and you'll head right back to the room. If anyone has any trouble heading over, we'll be in here for a few minutes, but we will be ending. And our next panel featuring Laura Talmas from Beyond Differences will begin sharply at 12:35. So you do have a few minutes if you need to get a restroom break or water break in. But thank you all again. I am honored to be among peers and colleagues and friends who are passionate about addressing social isolation and loneliness, and look forward to the work ahead. Thank you.